Hello everyone, good morning. I'm Sriram Somanchi. I'm an assistant professor at University of Notre Dame. This is a joint work with Idris and Ralph Cross at CMU and Disruptive Robotics. I know this title is a little bold, but the main point that we want to communicate is that we want to build tools that can help healthcare providers in their decision-making process. It is important to note that most of the data we use in this application and most of the applications in healthcare is actually generated by doctors and nurses. So we're trying to utilize the wealth of information that is available and try to hopefully provide actionable insights. Right? In this paper, we try to we want to understand the utility of machine learning methods in predicting hospital admissions from emergency department visits. And emergency departments are known to be chronically overloaded, but emergency departments are very critical decision points in hospital settings, both in terms of financial aspects and patient health situations. So we want to basically, we believe there is an information gap between the information that is available at the ED and the rest of the hospital. So we try to build that gap. We want to fill in that gap using some of the prediction methods which can understand and hopefully predict in a good way who are the patients who are at ED who might get admitted in hospital. So the approach we take is the current situation. A patient enters, is a triage information that is created, a room is allocated in ED, a patient is treated in ED, and at some point they make a decision that he needs to get admitted. That information is passed on to the inpatient facility, and they try to make the bed preparation. This is a typical process, and then after the bed is ready, the patient is discharged from the ED hospital. The way we want to approach is that as soon as a patient enters and some kind of information is created, triage information, we want to make a prediction whether the patient gets admitted in a hospital so that the bed preparation, if we are more likely that the patient can get admitted, we can start the bed preparation process earlier on. So that while the patient is getting treated in ED, his bed preparation is ready, so that we are trying to save the time that is left, and so that we are reducing the overload on ED and overcrowding in ED. And the thing is, we can also make a prediction as soon as the patient enters, based on his historical information, whether the patient gets admitted even before the clinical triage. And we'll see how well that is in terms of prediction, but that's one other idea that you want to keep you guys in trial. So basically use the triage information, make the prediction, and see how that is. So that's the overall setting. The data we have is about 5.5 years of data of ED patients, around 170,000 visits, and around 66,000 unique patients. Basically, we characterize the information that we use in making predictions to 3 different categories: clinical, historical, and environmental. Beyond understanding the utility of each of these, we want to understand the timing in which each of these becomes available. For example, like I said, historical information can become available as soon as the patient arrives in the hospital in an ED setting. So we want to understand all of that. And the important challenge in this scenario in making prediction whether it gets admitted or not is a highly class imbalance problem. There are not too many. There's only 17% of the ED visits which result in admission. I'm saying only, it's actually quite good in terms of patient outcomes because not too many people are getting hospitalized. It's quite good. But when it comes to task of identifying and predicting, it's a challenging problem because if just say predict everyone gets discharged, you're still 83% accurate by saying those people. But so you have to maintain the right balance in order to predict both admissions and discharges. So we use some cost-sensitive classification techniques for that. So basically, we tried different classifiers. I'm not going to go into details. Most of you have seen or heard about these classifiers. But the important result that I want to drive in the next minute or so, is that we try to understand the effect of each of these set of vectors that we have about the input characteristics and how they do. The first column, the AUC, is area under the curve. It's of ROC curve. Basically, it provides the discrimination power, how much we can discriminate among admissions and discharges. Historical information still as around 0.8 ROC, and with all the information, obviously, you have better accuracy. The second one is about the true positive rate. We still have good accuracy with historical information as it is, as soon as patient arrives. And with all the information, we have an 83% true positive. Obviously, for a fixed false positive, at 25%. So the second important thing is that using this mobile application they have, there's a guess or there's a signal that that these healthcare providers can send the inpatient facilities about some patient when they suspect he gets admitted, which is called soft requests. We're trying to understand our prediction accuracy in terms of what the human judgment in terms of sending those soft requests classifier. So the x-axis here is about the time in the hospital setting, and y-axis is an F1 score, which is a kind of a prediction accuracy. It's about precision and recall. We see that our prediction, which is the blue and the green lines, have good accuracy up until around 111 minutes or 120 minutes in the hospital setting. So we are making good prediction earlier on. As obviously more information the clinicians have, they're getting better in predicting this. So we're trying to see the quicker we can do this prediction and hopefully complement this information that is available from the healthcare providers and provide a combination of these results to make this prediction of people who are going to be in the hospital from the ED setting. So I'll be happy to talk more about and take your questions at the end of it. Thank you very much. Looking forward to your questions.
Do you have the insurance status of the individual as one of the features?
No, at this point, it's actually using a mobile application that they have. We have only triage information. We don't even have clinical or insurance information that is available. I realize that is probably one of the important decision-making process, but at this point we want to see as much we can do in this application setting we have.
Anecdotally, patients get pushed to be inpatients if they have insurance because the hospital can then charge their insurance company for the inpatient visit. So also the existing occupancy rate in the hospital is also going to be a big, an important criterion. Yeah.
Right, okay. Yeah, sure, that's a good point. We'll try to see if we can get hold of that information. Thank you.
Hi everyone, I'm the second speaker. I'm an assistant professor at Weill Cornell Medical College of Cornell University, and this work is jointly done with Professor Rama Patman at the Heinz College of Carnegie Mellon. So we have been working on clinical pathways for the last couple of years, and we've always wanted to see if we could incorporate the cost information to the pathways, but we didn't have enough time. So I had just graduated from my PhD program this past May, and I thought that I would have a lot of free time ahead of me. So we thought that perhaps it's a good time to start on actually looking at both the clinical and the cost pathways. So it turned out that I didn't have as much free time as I thought I would. But so this work that I'm going to present is very preliminary, and I would appreciate any comments that you have for this early stage of the work. So clinical pathways and cost pathways can mean different things. I wanted to clarify that ahead of time. So clinical pathways are pathways of clinical events over time, basically, and so it would include information on changes of encounter types, diagnosis, medications, and other treatments. For example, a patient may come in at one point in November, and I would also have the information on February, May, August, and all of these are identifiable from the electronic health records. And on the other hand, the cost pathways would be the pathways of costs that are associated with each of these clinical events. So for example, if we only look at the medication copays, the cost pathway would correspond to the copays of each of the medications that patients are prescribed by their clinicians. So in this early analysis, we've looked at the cost pathways and clinical pathways for 288 patients in Pittsburgh, Pennsylvania. They have multiple chronic conditions such as CKD, diabetes, hypertension, and so on. And the variables that we looked at are 4 encounter types, 19 types of diagnosis, procedures, and all of the patients' medications. And we also estimate the cost data for all of the medications copays that patients are expected to pay, but because we don't actually know if the patients have purchased or taken the medication, so there are some caveats around the cost estimation. But basically what we did is we took 2 approaches in looking at these patients. We said if we look at the clinical pathways and find patients with similar clinical pathways, and if we also look at their costs, would the would the clinically similar patients spend the similar amount of money? And it turns out, as you would expect probably from previous literature, is that they're not. We found that if we categorize patients by their clinical complexity, the categorization would show differences in their medical spending. And conversely, if we look at the patient spending, each of the patient subgroup will also show differences in their clinical complexity. So this is one of the findings that we have so far. And what we did is we went one step further in looking at actually their how would the clinical pathway differ for patients on different pathways, and try to go deep into the electronic medical records to show where the changes happen and what are the good and bad outcomes. So this is a visualization of the pathways among the low spenders. Everyone started out at CKD stage 3, diabetes and hypertension. So we controlled where the patient starts, and you can see that the pathways diverge into different directions. The green pathways would be the pathway that will lead to improvement in patients' kidney conditions. So that would be a good outcome. Whereas the red pathways that would be the bad pathway, where the patient's kidney conditions actually became worse. And the red parts that you see is the joint path that both the good outcome patients and the bad outcome patients shared along the way. So I'm not able to show you the details, but from looking at these pathways, we're hoping to find what are the good pathways and how much, depending on the range that we identify from the data, how much should a patient with particular condition cost. So we're hoping that this work could lead to some analysis into the different payment mechanisms, and potentially to say that if we can identify what good pathways of treatments, can we also say that how much this good this pathways of treatment should cost as a way to guide policymakers or management of a clinical practice.
Quick question, what's the thickness of the edges?
So the thickness of the edges represent the frequency of the pathway. So the thicker, the more common that we see in our data set. Yes.
When you look at stage 3, you're already with a nephrologist.
Yes,
And
yes.
and so it leads with the point of inflection. The point of inflection of whether somebody goes to dialysis is slightly after stage 2, and otherwise, and the cost goes to about 150 million per patient when it goes to dialysis. Otherwise, there are good outcomes, and there's a lot of work that looks at the timing of the referral to the nephrologist as the key factor. So if you capture the data from the nephrologist, you don't get the priors efficiently. And I just wanted to say that if you go to stage 2 and start picking up from there,
Okay,
you might
good.
be able to get a better outcome. Thank
Okay,
you.
great. Thank you so much for the suggestion. Thank you.
Good morning, everyone. I'm Ashwardeep Shukla. This is our early stage work to analyze fraudulent reviews. This is a joint work with Wei Kwong, Professor Gordon, and Professor Agarwal. And in this work, we look at identifying fraudulent reviews and trying to decipher which one is a genuine one and a fraudulent one. So this is how typically 2 reviews would look like on a review platform such as ZocDoc or Practo or any of the popular platforms. And as we can see, it becomes pretty hard to discern which of them is a fake review and which of them is a genuine review. And of course, it is very essential to discern this, because otherwise patients can end up being treated by a doctor who has questionable ethics and probably best avoided. So this work tries to detect fraud reviews, and this has been a growing concern in the literature. There have been studies recently that have used surveys to say that some doctors even admit that they pay for reviews and they ask their staff members to proactively write positive reviews for them. In case of Yelp, there are 17% reviews are fraudulent. Even Amazon has a sizable share of questionable reviews. So if we look at the past literature, there have been linguistic approaches to detect fraudulent reviews, which look at imaginative language as one key component. There have been work that looks at reviewer characteristics. So they look at number of new users coming in and just going ahead and writing a review as one of the ways to predict if it is a fraud or not. And what we add to this is we look at market characteristics. So we try to look at the underlying mechanisms which incentivize people to do fraud, the economic mechanisms such as the marginal benefit of an additional fraud. And to do this, we collect data from a platform in India which has a sizable number of reviews, a sizable number of reviewers. So if we look at average reviewer, his review looks something like this. But along with the review, what we also have is a host of system forensics data. This data is in the form of a cookie ID, a device ID, his affiliation within the hospital network. So whether he is a staff member of a hospital or a clinic. And these data helps us identify those reviewers who are likely to be giving very fraud reviews. And this is how we determine the ground truth. And we can do it for a very sizable sample of over 100,000, and we identify about 14% of them as fraud reviews. And then essentially we feed this data into a machine learning algorithm which tries to predict this fraud on factors which are exogenous to our initial determination of truth. So we use the text feature, that is the text of the review, along with then the specialty and city. We tried a host of algorithms, and the one that works best so far is random forest, and we get a pretty good low false positive rate and a pretty high false negative rate, which makes it very promising to be used as a algorithm for screening the reviews in real time. Further, we hope that by adding neural networks to it and by adding more market characteristics that predict fraud, we will make it reasonably robust for this work. And we hope that we would be able to create a model that is sophisticated enough that we would be able to capture fraud even when people move from a low cost, easy to identify fraud to a very high cost, sophisticated fraud. So this work tries to essentially capture economic incentives to understand fraud from a greater detail. Thank you.
So low false positive suggests that you already know you have fully classified the outcome as being either you fully classified the outcome as being a false review or a genuine review.
Yes, but yeah.
So I'm just curious, how did that come about? I didn't understand that new model.
So what we essentially are able to do is we are able to classify a section of frauds really well, but we are not able to classify the entire bucket really well. So if I have, say, 14% of fraud, I'm able to look at some of them and tell very well that these are fraud, but some other types I'm not able to discern very well.
Can you explain how you label the 14% that you identify as fraud? Because that's key.
Sure. So how I label essentially is using system forensics data. So I look at the parameters like the cookie ID, the device ID, the IP address from which the fraud is originating. I look at if this reviewer is affiliated to a hospital staff, so if he's say a receptionist, an accountant, and these precursors help me establish the ground truth beyond a reasonable doubt. And this has been a great challenge in most of the studies that look at fraud, because these data points are very hard to get, and to get something that would help us get to this level of identification is hard. We even use honeypot as a low-cost, easy to exploit system bug, which some doctors would exploit to enter into the system and write a fraud review. And this helps us easily track people who are using a low-cost, non-sophisticated fraud mechanism.
So I'm thinking about the people that work in doctors' offices and hospitals and so forth. So of course, they are also patients, and they're treated by doctors. So some of those reviews are probably going to be true. Do you have any estimate on what percentage of that 14% you think are not truly fraudulent?
So I would say that the best, so what we try to do is we try to tag those reviews which originate from the same hospital and the same doctor setting or their collaborators. But we try to still keep the reviews that I believe have no direct affiliation with this hospital. So if there is a cardiologist who's visiting, say, a dentist, then that review is still flagged as a genuine review. Whereas if a direct competitor or direct collaborator writes review, then it is flagged as a fraud review. Thank you.
Good morning. My name is Nirup Menon, and my co-author is Rajiv Kohli. So we are going to talk about balancing service quality, patient engagement, and hospital efficiency, and the role that IT plays in this balancing of these different outcomes. And our work was primarily motivated by the Centers for Medicare and Medicaid Services that recently started, I guess it's been about 4 or 5 years, but started to penalize hospitals by reducing their reimbursements based on a performance score that includes service quality, patient engagement, and hospital efficiency. So one of the things that we were looking into is how do hospitals balance these different outcomes, and how health IT might impact they are balancing these different outcomes. Because it's not clear that these outcomes are all going in the same direction, but there are rather trade-offs between these. So if you increase quality on one hand, you're probably going to increase costs on the other hand. Or if you increase satisfaction of patients, then you're going to increase the costs of the hospital. In general, we know that from an academic point of view that efficiency research has been going on about efficiency of hospitals, that is, for at least past 4 decades or so. And even quality has been, people have been working on quality for some time now. And more recently, this issue about patient engagement has come up. So the question is, does all of this, so as I said before, these different outcomes, we need to start to consider them together, because it's not clear which one affects which other outcome and how IT plays a role. So as I said before, these outcomes have an impact on each other. And for example, patient engagement, right? That refers to how responsive the medical staff is and how communicative the medical staff is, how that affects for example, the clinical prevention standards that are being implemented, that impacts the patient satisfaction, right? And also we see that, or we are trying to look at whether following these patient satisfaction and these qualities such as the clinical prevention standards, reducing safety failures, does this really affect, how does it affect the cost? And if you look at it, all of these outcomes actually follow a temporal sequence in terms of as the patient visits, patient is admitted, and post-patient visit, and post multiple visits of the patient. And as I said before, the CMS is playing a role here in trying to encourage hospitals to follow all of these different outcomes. And so in some ways we think of, we can think of this as hospitals and insurers trying to share the risk between each other. The impact that we are looking for is what value does IT bring into this equations of these different outcomes. So when we talk about IT, we mean the health IT infrastructure, which is the underlying back-end kind of mechanism, and the usage of EMR, which is the more service-enabling component of the health IT. And in going into a little more detail about the model, we are looking at, by the way, this is a preliminary work, so any feedback is welcome. So currently we are looking at a very big model in which we are looking at whether the adherence to standards affect safety failures, how they affect mortality and readmissions in the long run, how patient engagement during the visit affects mortality and readmissions, and how all of that impacts the efficiency of the hospital. So in other words, how does it affect the penalty that eventually the hospital pays in terms of reduced reimbursement from the CMS? And of course, our impact is on the, our research is on the impact of IT and EMR. So we are looking at these relationships as well. Our data is from HIMSS Analytics, Hospital Compare, HCAHPS, and other kinds of data in CMS. I'm running out of time, so I'm going to directly go to the results. We find that, yes, health IT and EMR do play some moderating roles. In fact, I'll just highlight one in the interest of time. For example, we find that if there are, if patients are more satisfied in a hospital, then more likely readmissions are lower in that hospital. So we think that, and we find that HIT and EMR actually boost this impact between patient satisfaction and low readmissions and mortality. So thank you very much.
Interesting work, Nirup. Question I have is, why do you call that cost inefficiency, or I think cost efficiency? You label that your final outcome.
Right.
So CMS, I believe they look at both quality and cost. When they look at your penalties, you can't trade off one against the other. So shouldn't you be, when you calculate your efficiency, shouldn't it be a metric that is based on both together, both the quality and the cost? So if you think of a ratio, it's cost over quality, or quality over cost if you flip it,
Right. So there is an impact between quality and efficiency. So if you go to our model, for example, the other way to look at it is the performance score that the CMS calculates is a weighted score of the adherence to clinical prevention measures, safety failures, quality outcomes, and cost efficiency. So how much Medicare is spending per beneficiary is a part of that formula. So we are saying that even though they're using this weighted score, there is a relationship between these different outcomes. There's a trade-off, because you increase one, the other decreases it. So hospitals have to play that really the tight balancing game between these different outcomes. Olivia.
So related to your work,
Okay.
what kind of data did you get for HCAHPS?
Uh,
Is
fro-
it hospital level and temporal, or?
It's hospital level, and also I forgot to say it's temporal because it is over 4 years of data. And I also forgot to say that it is in between, like 2010 to 2011 is the data before penalties were started to be imposed, and 2013 and 2014 is the data when the penalties were imposed.
Is there any potential to get most granular HCAHPS in your data set?
I believe there is, you can get from the hospital level, and I think my co-author is working on some other project in which he's getting patient level HCAHPS data. Our research is completely at the hospital level.
Thank you. Can I ask a question related to, have you considered readmission as whether the ER patient was a second visit or a repeated visit?
Yeah, I think we have actually used the historical information that I was using.
Right.
Uses a temporal information actually. It uses like last month, last week, last year, how many times a person comes in, as well as what was the like result of that ED visit, what was the acuity at that ED visit. All that information historically is captured in that. So
Okay.
we did use that not only just last month, but also historical different time windows for last year or so.
How about duration of ER visits of previous
Yeah, I think we've used that as well. We have the length of the stay for the in the
During
visit.
the-
We use that information as well. I specifically don't remember exact utility of each one of them, but we did use a lot of length of information.
were they predictive? Did they have predictive power?
So that was I was talking about the historical by itself with all of this information, including the number of visits as well as length of stay and as well as like the what do you call the acuity of the historical. All of that was really useful. With that information itself, we had good accuracy. Obviously, using the current information of this ED visits adds on a lot of value as well. But even just historically, as soon as a patient comes in, we can have good amount of accuracy whether the patient gets admitted this time.
Yeah, I think your in IS community and also your medical audience, they will be very interested in teasing out a little bit more down to each category that what made them predictive, because that will give them some potential insights to improvements.
I agree. I mean, I have it in the paper, but I can present, for example, a logit or logit loss, so we can identify each specific coordinate, how much it adds out with, or log odds ratio of predicting. So I can do that. But that's really important. Thank you.
Thank you.
I have a question for the fraudulent reviews. So do you only capture positive reviews, or are you also looking at negative reviews?
We are looking at both positive and negative reviews.
Okay, so here's what I'm thinking. There could be a negative review that is actually meant to be positive for somebody else. If there are two doctors in the same office building, you'll capture the same IP address, but I'm actually talking down the other guy because he's my competitor.
Yeah, so if you say if doctors in the same market, say same city and specialty, are writing reviews for each other, and I have evidence that it is posted for each other, then I would mark them as suspected fraud reviews, even if they are positive or negative.
So you are looking into that.
Yeah.
So interestingly, I think Ashwarya has found that there are doctors, right, who are so generous and giving ratings to his peers, his competitors, positive reviews.
Yeah. So there are reasons why doctors would give positive reviews to their competitors as well, and the essential reason is that it becomes very hard to take action against such fraud reviews, because the competitor is getting benefit for no reason at all. So if you delete those fraud reviews, then the entire market becomes very volatile and very protestive of the action taken against.
So can I ask a question? So what about if a patient logs into the network while in the waiting room and submits a review? That would be a local submission, right? IP address.
So in those cases, the IP address would not be taken into consideration typically, because we look at the cookie ID, which is specific to the browser. So if it is patient's own device, it is okay.
Along the same lines, there are certainly sites, Amazon, for example, that validates the existence of the person, that it's not an anonymous review. It's a known person, and you can look at their other reviews. Are you looking across at a person level to see what's their pattern of doing reviews? Because someone who comes in and does 300 reviews in a matter of weeks or something may obviously be a more likely fraud. And someone who gives a mix of positive and negative reviews that look consistent, like they're actually doing them in a way that would be consistent with somebody receiving services.
Yes, so we do look at respondee level frequencies to track fraud, but most of it is also picked up by the system forensics data. So essentially, we are trying to use system forensics to build the ground truth, and then use the underlying economic reasons why would they do fraud to predict that. Because I believe that if I try to prevent people from writing fraud, say if they're writing very frequently, then they would get attuned to this kind of penalty and they'll make it regular and far more spaced out and hence far more difficult for the system to pick up in the future.
Are all the reviewers anonymous, or is there a mix of anonymous versus identified reviewers?
So when the reviewers post a review, they can post a review to be anonymous to the public, but because I collaborate with the platform, I would know their credentials in all the cases. But they can post an anonymous review
And
as
do you
well.
find any difference in fraud frequency between anonymous reviewers and identified reviewers?
Yes, the fraud frequency is higher for anonymous reviewers than non-anonymous reviewers.
So I enjoyed all your presentations. Thank you. I have a question around prediction in the context of just clinical settings, actually. And I think some of you work on this in various kind of situations. And Ritu's question actually triggered this. So we typically use historical data to build models about prediction, but historical physician behavior may not be the best behavior for patients. So if insurance, for example, is an important predictor of whether somebody gets admitted, right? Is that really normatively the right decision, right? And also around readmissions, right? So if hospitals are trying to strategically avoid readmissions, they may actually choose not to admit somebody if they came within the first 30 days. Is that the best outcome for patients? So in kind of your experience around this context of healthcare, I'm curious, anyone on the panel can talk about what do you do? What's the implication of that?
So I think it's very fair point. At this point, like I said in the very beginning, we're trying to use the wealth of information that is actually created by doctors and nurses, and we believe at this point when we're trying to build, we're trying to replicate as much as possible as doctors' decisions and nurses' decisions. And there's a further metaphysical question about whether those decisions are actually biased by themselves or not. Is that actually good for patient outcomes? So one way to do that is to even in this, and I'm sure even in the application that Aishwarya was talking about, is that these labels that are created, whether for in my case admissions or discharge, or his case like fraudulent or non-fraudulent, can be assumed by itself as some kind of a noise in them. And there are in which you can assume how much noise, how much in these labels, and then try to correct for those biases that are available. But obviously it comes down to who's actually telling you those bias. How much is the bias you can assume. You can build analytical models on top of that and get an understanding. But still it has little gray area in my understanding, and obviously other people can comment on it. But I believe that's a little gray area that needs to be really fixed because that can cause problems in terms of our efforts to predict something for best outcome for patients.
Can I respond? I think you have touched upon a very important challenge, okay, to prediction overall. Okay, there are situations where there's very little modeling and testing can help with. When situations such as market crisis, those drastic up and down that you cannot quickly adjust to. But in analytics modeling, it's very important that you test it right. So in cases like this, besides holdout testing, cross-validation, you also need to do time-dependent testing, that you apply past data to build model, and build model using past data, test it with future data of past data. So future is still in the past when you're testing. And you do this ongoing application. So the richness of healthcare is if you apply, you immediately get feedback from current data and the next day's data to go back and adjust model. But those very drastic changes, it's going to be very, very hard to predict. Some historical crisis or very rare events can train that, but very low accuracy. So I don't know whether that's related to your question, but that's a very important principle for predictive analytics research.
Just to comment on Olivia's comment for just a second, the challenge with healthcare is that the body of evidence is also changing. So what you base your decisions on 2 years ago might be completely different as to what you might base your decisions on today or even 1 year down the road, right? So if you have too long a time span that you're using to train your classifier or to train your machine learning algorithm, you might be picking up noise that you can't explain.
That's exactly true. That is paradigm shift. Internet marketing cannot tolerate 2 years model. Okay, you adjust recommenders weekly, overnight, or whatever, right? And like the clickstream data for reviews that can come in in data streams that you can regularly collect, and you can adjust the time. And I do understand this hospital ratings and reviews and payout and penalty and that come not as regular. So there are difficulty based on data frequency, data availability. And if healthcare really find benefit of this, then the rating system should also have another startup to come up with hospital ratings or something that could help make more real-time predictions. So there's lots of potential innovation related to how to create data to make prediction more timely or real-time. I hope that's useful.
Yeah, this is more a general comment about prediction in general in the healthcare system. And I'm wondering, in terms of driving adoption and faith in the prediction tools that you're developing within healthcare, might it be better to focus them in on mortality rates and activities that reduce mortality rates? Because when you look at something like, let's say, the bed preparation, it strikes me from doing a lot of work with clinicians and with healthcare environments that if even 4 or 5 beds are prepared in a day that are not used at the end of the day, that will reject that system straight off. So in a system where at every point in the system resources are stretched and overloaded, any pressure that's added to any point in that chain, even if it's with the goal of reducing pressure at another point in the chain, just won't wash. So I'm thinking that eventually that should work, but in order to drive adoption at the outset of these techniques, then it might be better to look at something that reduces mortality risk rather than just creates a small efficiency, potentially or not, within a really overloaded chain the whole way along.
Yeah, I completely agree. How much value at this point we're trying to see, it's like, I'm trying to vaguely say we're saving time in bed preparation, but your point is well taken, that we want to understand how much that affects other outcomes in terms of mortality rate or even hospital-acquired illnesses or any other outcome that you can understand and see the effect of these on that. I agree, but at this point, I just want to acknowledge that we just have the data, we're looking into it, it's preliminary. Hopefully with more information that we can and more collaborations that I can make, we can collect that information and also understand the downstream effect of these predictions on more general outcomes, for example, like mortality rate. I completely agree.
Okay, yeah, so thank you for everyone.